I'm going to go ahead and get started here. I'm going to talk a little bit about, we're going to talk about a little bit, review things, give a couple cases, and then we're going to start talking right away. So we talked about pharmacokinetics a little bit in the first lecture, bioavailability, talked about half-lives. A little bit of definitions before we get started related to whether a drug is an agonist, antagonist, partial agonist, or antagonist-agonist at the receptor site. And you'll see me talking a little bit more about the specific drugs and where they work. But this is a little bit to introduce you to the different opioids and narcotics I'm going to be talking about and specifically where they work. And it's important to know how these drugs work because then you can add additional medications, and the medications that you're going to be adding, you'll know specifically how they work in the body and whether you're causing additional harm to the patient or actually treating them for their condition. So a simple definition with an agonist is a medication binds to a specific receptor site, okay, and it actually stimulates this receptor site so you get more activity on it. An antagonist is a drug actually binds to that receptor site or kicks the drug out that binds to that receptor site, and you get the opposite effect. So really simple definition, morphine is an agonist at a specific receptor in our CNS. It's called the mu receptor. It's associated with relieving pain. Naloxone, okay, that is an antagonist drug that will kick out whatever has bound to that mu receptor, and then you get the opposite action, okay? Partial agonist, I have a couple examples of that, but that would be something that maybe weakly binds to not necessarily the specific receptor, but maybe a side part of the receptor. It doesn't initiate as much stimulation and this full stimulation that you would complete agonist, okay? And then a partial agonist would be the opposite of that, an antagonist and agonist effect. So even though I've just given an example of like just a mu receptor, there's a lot of different receptors that are associated with where opioids bind in the CNS, okay? Now some of these receptors have different properties to them, and some of them actually have negative properties to them, okay? So narcotics or opioids bind to, there's the mu receptor, there's a delta receptor, and there's a kappa receptor. And each specific opioid binds to a different ratio of those three receptors, okay? A partial agonist antagonist would have agonist activity at some of those receptors, okay, and antagonist effects at different receptors too, all right? It's a little confusing, all right, but I'll give you some examples in about 10 or 15 slides, and I'll explain the differences in between them. So the pharmacokinetics, the half-lives of medications, they differ based off of the patients that we're going to be looking at. So if it's a child, it's going to have a smaller kinetic or smaller volume of distribution. Their half-lives can be a lot different. Their metabolisms are usually a lot faster, and they start metabolizing drugs a lot faster. Their livers are working fine, their kidneys are working fine, they're excreting drugs perfectly fine, okay? There's also differences in how these medications work in the body, how things work on different microorganisms, and that's to be explained a little bit, differences between the different pharmacokinetics and pharmacodynamics between patient populations. So the more DNA mapping that we're doing, the more studying that we're doing on metabolism of medications, the more that we're finding out about different subset populations, maybe either metabolizing drugs slowly or not metabolizing drugs at all, okay? So sometimes when we take medications in, for example, codeine, and you never really see codeine used anymore, okay? And because there's a lot of differences in pharmacodynamics with how codeine actually works. So codeine in the body, you either take it in a pill form. There is some rare formulations that are available as an injection. The body metabolizes codeine into its active form, which is morphine in the body. Morphine acts, it binds to the mu receptor. You get an agonist effect at the mu receptor, and you get pain relief associated with it. All right. But what they found out in the mapping of codeine is that there's a specific receptor in our liver that's responsible for metabolizing codeine from codeine to morphine. And it's this, the P450 system that I talked about last time, but it's a specific isoenzyme called 2D6. All right. Certain subset populations have or are poor metabolizers of and have a lot of decreased amount of this isoenzyme 2D6. So you give them codeine and they get no pain relieving properties at all. Because why? Doesn't metabolize into morphine. So you keep giving them more and more and more, and it's still not going to work. All right. This is one example of changes in pharmacodynamics from one patient population to another patient population. Okay, and we're finding out more and more about this. All right, and as new drugs are available, we start mapping out to see how actually they're metabolized, how they're excreted from the body. You know, for a long period of time, Plavix was out in the market. No problem at all. Okay, certain patients who were on Prilosec were taking Plavix, and they ended up going for repeat stents all the time. Well, it turned out that Prilosec was actually decreasing this active metabolite of Plavix. All right? So there's a drug going on. There is some pharmacodynamics that were going on for those specific patient populations. So that was a specific drug interaction that was happening. So cardiologists found out about this. They were studying it in clinical trials. They took patients off of the Prilosec. They kept them on the Plavix, and everything was fine. There's also some newer drugs out in the market too, besides just Plavix, that help with inhibiting the platelets. There's a new drug called Brilinta. There's also another one. The generic name is Prasugrel also. So both of these drugs, even though they have antiplatelet effects, they don't have that drug interaction. So they have different pharmacodynamics associated with them. So first case. JK, 39-year-old female, walks in the ER at Waukesha with a chief complaint of a migraine. Her past medical history is diabetes, hypertension. Vital signs are heart rate 70, blood pressure is 120/81, respiration is 18. She has had nausea and vomiting since she arrived, and she was given 2 doses of Zofran IV. Transport called because the patient's migraine is not getting better, and the CT is abnormal. Now the patient wants to go to Froedtert Hospital, where the patient's neurologist is at. Before transport, the patient complains about additional nausea, vomiting in the ER. Physician gives her some medication. Which of the following is a good choice? Oops. So what do you think? Zofran, Reglan, prochlorperazine, droperidol, or promethazine? Now, how many of these medications do you actually in your rig? There's a statement coming up. So they gave 2 doses of 4 milligrams in the ER, did nothing. Okay, so I could say that those receptor sites and where the drug is actually working are saturated. All right, the drug's on board. The mechanism of how it's working is working. All right, but this patient specifically is not responding to the Zofran. Okay, so we need to change it up. So different mechanisms of action for all these other 4 below it. Okay. Check the patient, see if they have any allergies. If they don't have allergies, any of the bottom 4 would have been an appropriate choice. All right. So like we started talking about today, patients respond different. Not everyone is going to get better when you give them a medication. All right. They may be these rare patients in clinical trials that don't respond at all to the first agent that you give, which is Zofran. Okay. Now, are you going to harm the patient if you give them additional Zofran? What does everyone think? I hear no. I hear no shaking. Yep, yep. Probably not. However, in the past year and a half, past 2 years, Zofran's been stung by what's called a black box warning. Black box warning is put out by the FDA. The Food and Drug Administration looked at post-FDA approval data associated with Zofran and found out what? Prolongs QTC. The bigger the dose, the more prolonged QT you get. All right? So, if you're going to give it, put them on a monitor. Watch them. You don't need to do a 12 lead, okay? But at least put them on a monitor. Headache and constipation. That's a big side effect with it. Yeah. So, person's coming in with a migraine, nausea and vomiting. You keep giving them Zofran. Now along with, not one medication is going to work for 100% of the people that you give it to. That's true. All right. And not 100% of the people that you give that medication to is going to get a side effect of that medication. Okay. But in those rare instances that a patient does get a side effect of that medication, you need to record it, you need to document it, and then biggest thing is don't do it again, because the side effect is probably just going to get worse and not get better. Chooses Reglan, all right? The nurse grabs the medication quickly and gives the medication before transfer. 5 minutes into the transfer, patient starts to complain about her facial muscles are starting to twitch, all right? The neck is really getting stiff. She states that she can't keep still, and keeping her on the bed becomes very, very difficult. You notice that the tongue is moving awkwardly. I think that's related to the abnormal CT finding, okay? So could this be associated with Reglan? And if so, which of the following medications could you use to treat? So, what do you think? I hear a C. All right. So, back to answering your question. Is it an allergic? You give Benadryl all the time for allergic reaction. Is it an allergic reaction? I hear no. Side effects of the drug. All right. I heard a dystonia out there. All right. That was one of the things that was happening with the patient. All right. So the bigger picture of what's happening, this whole thing is called extrapyramidal side effects. They abbreviate as EPS. A subset of EPS are multiple things that can be happening. Dystonia is one. Akathisia is another one. All right. That tongue rolling, that tongue protruding out and rolling around, that was another side effect. Pseudoparkinsonism, that's another one. All of those side effects fall under what's called extrapyramidal side effects. So when you look it up in the textbook, or when you look it up in your drug reference and you see EPS, well, that tells you a big thing of what, but there could be a lot of subset things that could be happening. And you read on throughout your textbook when you look it up, and it says specifically what can be happening, okay? So this patient was actually suffering from multiple things. Let me just back up right here, and I want to show you. So facial muscles started to twitch, all right, and the neck is gradually becoming stiff. What is that side effect? That's probably dystonia that's setting in, okay? That usually the patients that come in, and it's not only related to Reglan, but it's related to also antipsychotics too. A lot of antipsychotics, those other nausea vomiting medications that we talked about, prochlorperazine, that's another one that you can get dystonia for. So the patients will come in, and sometimes they're not in pain, but their neck is just, their head's connected to their shoulder, and they're just kinked like this, and they're scared half the time. They just don't know what's happening, all right? It's associated sometimes with an increased dose of antipsychotic medications. Sometimes it can be associated with giving the medication too quickly, all right? You give it too fast, maybe they're just getting ready to transport, and the nurse comes in and just, here's your Reglan, you know that? Your problem now, guys, hit the road. And you're like, thanks. What about this other one? Becomes not being able to sit on the bed, not being able to sit still. What's that called? I heard akathisia. Yep. That's this interrestlessness, it's called. It's often described. That's, I'm going to pull my IV out. I'm leaving this hospital right now. I'm jumping out of the back of your rig. I'm not staying for this. I know what you guys gave me, but I'm not taking it, all right? Now, they may walk out and they'll be just fine. They'll calm down. But you as providers and you as people that are transporting need to recognize what's going on when you call, when you get an order for something else, treat the patient appropriately. All right, what's the tongue moving around and stuff like that? What's that called? That's something, it's another extrapyramidal side effect. I don't want to misquote it right now, but there is a specific name to it. It's not pseudo-Parkinsonism, because that's usually this shuffling gait that's associated with it and kind of stagnant. But I'll look it up during the break, and I'll let you know specifically what it is, and we'll come back to it. But for some reason, it's escaping my mind right now, and I can't think of it. All right, so everyone in the room wants to get Benadryl, all right? Not allergic reaction, okay? You have an imbalance of anticholinergic and cholinergic effects with this medication, okay? And to balance out this anticholinergic and cholinergic effects, you give a medication that's anticholinergic, all right? So anticholinergic, dry eyes, dry mouth, these are side effects of the medication, but you're leveling off this balance. And that's the same thing with antipsychotics. This whole balance of anticholinergic and cholinergic effects have tipped. So where you're getting a lot of these extrapyramidal side effects, and you need to level that off, okay? It's not the antihistamine effect that Benadryl has that's helping this patient, all right? It is an antihistamine. You give it for allergic reactions. You have this all amounts of antihistamine released. You want to block that histamine from binding to that site. You want to block the swelling, the redness, the itching, everything else. It's not that. It's the anticholinergic effects of it. There's other medications like Cogentin is the brand name, or benztropine. Has anyone ever heard of this medication? No? Okay. That is another medication that you can give. Doesn't have an antihistamine effect, but it balances out this anticholinergic and cholinergic imbalance that the patient is actually having. All right? It'll work just fine. Sometimes in the ER, these patients are treated with benztropine instead of Benadryl. All right. So metoclopramide or Reglan, it works a little bit different because it actually binds to the D2 receptor. It's similar to antipsychotics. And because of this effect, it has all these extrapyramidal side effects. So if you want to think in your mind, if you want to categorize and file this away, all these signs and symptoms, all these side effects are going to be associated with antipsychotics, Reglan, okay, and also compazine or prochlorperazine or metoclopramide. All right. Any questions about that? That was a little bit of a review. We didn't talk about metoclopramide last time. We talked about prochlorperazine and promethazine, but I think it was a really good example in what you would use in the field. So I brought it up again. So a little bit of transition and a little bit of review for this first couple slides, but what I want to transition and talk a little bit about is diuretics or water pills. So you probably won't be doing a lot of giving these per se. Maybe a little bit. How many people in their rigs have furosemide? I got a handful of people. Okay, so that's probably the most common one that you'll see out of the list that's up here. You may look at med lists and you may see the other ones that are on here. If you're going to be involved with critical care transport, they will either give one of these two agents, the bumetanide or the furosemide, initially, and then transport them to another institution. Both of these agents, bumetanide and furosemide, are available as IV infusions. Okay, so it's not as common as it once was, maybe about 10 years ago, to see a patient on what we call a Lasix strip. Lasix is the brand name for furosemide. These are patients that maybe are a little bit hypotensive. that can't really tolerate boluses, but you admit them to the hospital and gradually diurese them over time. All right. Another case for you. MV, 68-year-old man who presents to you for the first time complaining about increased shortness of breath on exertion and increased leg swelling for the past week. He was prescribed furosemide 40 milligrams in the morning about a year ago for swollen ankles and has been taking it intermittently. He also has osteoarthritis managed with diclofenac twice daily when required. He states that he's been eating out at restaurants a lot over the past couple of weeks, and he said that he's gained about 15 pounds. Which one of the following is a good diuretic to use? So I flashed up the diuretics, all the ones. So furosemide, bumetanide. There's hydrochlorothiazide. There's chlorthalidone. There's metolazone is another one. I've only given you 4 different options. What do you think? You might not know this answer, all right? But I'm gonna be talking a little bit about it. Which ones that you can give. So, first of all, are all these diuretics or not? No. All right. So B is metoprolol. That's kind of thrown in there to kind of distract you. But either one of the bottom 2 you can give, and that's perfectly fine. So what about the routes on here? So first one's orally. The last 3 are all IV. We'll just throw this one out because that's a beta blocker. But last 2 are IV. Would you ever want to give someone an oral medication? All right. And why not in this specific case? So we talked about before bioavailability, all right, and absorption. So you got to break the tablet down. It's got to get kind of broken up, and then it's got to get absorbed into your bloodstream if you're taking a tablet. And it's got to circulate around, get into your kidneys, and start working into your kidneys to kind of diurese and get rid of all this excess fluid, all right? If you have an IV in, use the IV, give the medication right away, gets in your bloodstream. You don't have to worry about that absorption issue. You don't have to worry about the bioavailability of this drug or how much actually gets absorbed because 100% of it gets absorbed. You're giving all the medication into the IV. Starts working right away. All right, so how does, this is a little picture just to kind of let you know, but how does furosemide or bumetanide work? Does anyone know? It opens up water channels. It works a little bit different than that. So this is what we're talking about, the kidney right here. Okay, within the kidney, there's a specific smallest operating unit, which is called the glomerulus. This is the Bowman's capsule. So all the blood, pretty much from the body, comes into the kidneys, into this one single operating cell within the kidneys, and it's filtered. Okay. So the afferent blood supply goes to this glomerulus. All right. The efferent blood goes out of the glomerulus. So all the excess fluid, all the excess salt, whatever needs to get filtered out pretty much gets filtered through this glomerulus. Okay? Now, when the blood is coming out of the glomerulus after it's pretty much filtered, all the blood supply gets wrapped around all these other tubules throughout the kidneys. Okay? So it gives the body a chance to reabsorb if there's too much being filtered out, but it also gives the opportunity to excrete more if the body needs to excrete more. Okay? So where do furosemide and bumetanide work? You've heard about it be called the loop. Yep. The loop of Henle right here. So right after the blood gets filtered right here, it goes into this loop right here. And so if too much water is excreted, too much salt, potassium, whatever is excreted, this actually, if anything goes into this tubule right here, it eventually ends up into the urine, the collecting duct, and then goes into the urine, okay? But the body has a chance to absorb the rest of these things that get filtered out of the glomerulus. Now, Furosemide, bumetanide, they work in the loop of Henle. They're diuretics. They're very, very potent. They're more potent than the other ones out there. But they block the reabsorption of a lot of electrolytes in this first part. That's important because if they block the reabsorption of all these things in this first part, then all the rest of the fluid can continue down and collect into the ureter and then get excreted out into your urine. All right. Now they specifically work on some electrolytes like sodium, chloride, potassium, and to a lower extent calcium and magnesium. Okay. Bumetanide, the first one I'm going to be talking about, is a little bit more potent than furosemide. So why as drug companies, why do they develop multiple things? Why can't they just make it easy? Why can't we just have furosemide instead of two? Well, what's that, to each their own? Different populations. Some patients may tolerate one and not the other one. Some patients may have an allergic reaction to one and not tolerate the other one. All right. Now, in the past 2 years, interestingly enough, furosemide, there was a shortage on it. So I don't know where a lot of these shortages are coming from. They all have different reasons why certain drugs are short, whether it's a raw material shortage, one pharmacy plant closes down, the other one can't pick up the slack and can't produce as much drug, so then there's a shortage of it. So the reason why I'm talking to you about bumetanide is that this was pretty much the only other loop diuretic that was potent enough that it could work in patients who needed a lot of excess water excreted from them. So a lot of people were using bumetanide instead of furosemide due to the shortage. All right. So you need to understand a little bit of the differences. Bumex, the brand name for bumetanide, is a lot more potent than Lasix. 40 milligrams of furosemide is equal to 1 milligram of Bumex. So not to get that mixed up. You don't want to be drawing up 40 milligrams of bumetanide and be giving it to a patient. You always want to make sure you know what drug you're looking at and how much you're drawing up. All right. As far as volume-wise, you'd have to get a 60 cc syringe just to get all that Bumex in a syringe. Okay. So it's pretty much indicated only for patients who have excess water volume, increased water volume. This patient, the example that I was giving you, the patient said that they gained 15 pounds over the past week. Well, I don't think the person's going to a all-you-can-eat buffet, Golden Corral every single day, so it's probably not increased adipose tissue, okay? But it's probably all water weight, okay? They're complaining about shortness of breath. They're complaining about increased swelling, edema on their ankles. They need a diuretic, or they need something that works specifically on that loop of Henle, all right? So a little bit of caution behind it. Cautious on those patients who are hypotensive. Just like Deltizam, when we talked about it before, you don't want to go slamming into medication. Same thing with furosemide. You want to give it slowly, all right? The faster you give the medication, the more hypotensive that you're going to get. Now, obviously, it's not going to work right away. It's not going to affect heart rate. It's not going to cause some vasodilation, but it'll eventually cause a lot of excretion of excess water and fluid. And with that, all this excess excretion of water and fluid, you're going to cause decreased intravascular volume, which is then going to lead to hypotension. Does this all make sense? Okay. So things that you want to watch for, obviously patients who have an elevated BUN or serum creatinine, you're not going to know this in the field. You know, if you're going to be doing a transport from one institution to the other one, you may have their labs and you may look at them. Most of the time, to either the left or to the right of their lab values will be their normal range. So, or you may hear it in a handoff when the nurse is giving you a handout or the doctor is giving you a handoff when you're transporting a patient. They say, well, this patient's having some difficulty in increases in BUN and serum creatinine. This is related to an acute renal failure for this patient. Be careful if you're going to be giving any additional Lasix. Make sure to tell the next institution that. Okay. So with the excretion of excess fluid, water, there's always that tendency for cramping, hypokalemia, because we're blocking the reabsorption of sodium and chloride and potassium, also calcium and magnesium. So if the drug works by blocking the reabsorption of sodium, potassium, and chloride for the most part, how does it get rid of fluid? Water follows sodium. That's always the case. So you heard about, patients who are on heart failure are on a low sodium diet. All right? They're on a low sodium diet because you don't want excess sodium on them because they're going to retain more fluid. All right? You decrease the amount of sodium that they get in their diet, they're not going to swell up and they're not going to blow it up as much and they're not going to get all this water retention. All right? The diuretics use it in the opposite way. So they block, let's go back to your picture here. So they block all this reabsorption of sodium and chloride and potassium in this first loop. It keeps all the sodium and chloride in this loop, and it gets excreted into your urine. And with it, you're not going to get all this reabsorption of water. So all the water is going to stay there. The patient's going to diurese a whole bunch. All right. Questions about that? Usual dose is 0.5 to 2 milligrams IV. It's all depending on what their home dose of diuretics are. The good thing about Bumex is that the bioavailability is pretty much 100% if you're going to take an oral version of it. So let's say the patient was being compliant on Bumex, and their home dose of Bumex was 1 milligram every day in the morning. And they're complaining about increased swelling, shortness of breath. What dose do you want to give the patient in the rig while transporting them from either the field to the hospital or from one hospital to the other one? Knowing that the bioavailability of the drug is 100%, I'd probably say twice if they're compliant. If they're compliant. And you get this, sometimes you get the story like, it was Black Friday and I didn't want to take my water pill because I knew I was going to be waiting in line all day long and I didn't want to go to the bathroom. So I didn't take it on Thanksgiving because I was around relatives. And I didn't take it on Black Friday because I was shopping. Now it's Saturday. I'm swollen up like a balloon. Well, that's compliance. That's an issue. So, giving them your usual dose is probably enough. All right? But in a case where their compliance is 100%, they're taking it fine, there's no problem at all, but maybe they're eating out more, maybe they're getting more sodium in their diet, increasing the dose is perfectly reasonable. I know this isn't the best thing for you to do, but everyone has fluid on the rig. So if they become a little hypotensive, give them a little bit of fluid just to counterbalance that. Now, even though you're giving IV diuretics, it's still going to take a little time for it to work. 45 minutes to an hour is a reasonable estimate for oral. If you're giving IV, maybe 15 to 20 minutes before it starts kicking in. All right. Some of the nurses that are mean in the ER, they give the diuretic right before they go up to the floor because they don't want to worry about that. But those aren't the nice ones, so we won't talk about those. Okay, furosemide diuretics works the same as Bumex, bumetanide. So it blocks the reabsorption of sodium, chloride, potassium, to some extent calcium, and to some extent magnesium also. Blocks the reabsorption in the loop of Henle. All right. So you may start thinking in your mind, well, what's the rest of this tubule used for? If we're just using on the first part of the reabsorption of this loop of Henle, what if we're just blocking all the reabsorption there? Well, we're blocking it at the first part of this loop of Henle because that's actually where a lot of this sodium, chloride, and potassium actually gets reabsorbed. Okay? I would say 90% of all your sodium, potassium, and chloride gets reabsorbed here. If you block that, you're going to cause a lot of diuresis. The rest of this convoluting tubule There's a proximal, there's a distal convoluting tubule that loops around a little bit more. I think this next picture may show it a little bit more. But that doesn't filter as much, and that doesn't cause as much reabsorption on the other side of the sodium, the chloride, and the potassium as much as that the loop of Henle actually does. All right, so same warnings, same precautions. Patients who have elevated BUN serum creatinine, patients who are anuric, you want to use them a little bit more cautiously in those patients. All right, this specific one talks a little bit about using it cautiously in patients who have a sulfur allergy. All right, now I know many patients who have broke out in a rash because they have a sulfur allergy that tolerate furosemide just fine. There's no problem at all. But you, as people who are administering medications, need to A, ask them what their allergies are, B, recognize that there is a potential for an allergy, okay? And if you don't feel comfortable, definitely call med control and ask them. Say, hey, you know, this patient does have a sulfur allergy. Do you want to give it or not? All right? So if the patient is taking oral furosemide at home and you just want to give an IV dose, they're going to tolerate it. There's no problem. Even if they have a sulfur allergy, it's going to be no problem at all. All right? Things to also watch for with furosemide, you know, cramping. Sometimes these things can be what we call ototoxic, so patients can say that, you know, I'm having a little bit ringing in my ears. If they state that they're having ringing in their ears, stop the medication. All right. There's other medications that are ototoxic. This can have an additive effect to those other medications that are ototoxic. So just be careful. Monitor the patient, watch for these side effects, document them, and if anything like ototoxicity or a rash starts developing, redness up the IV site, obviously stop it. Okay. So what does that whole sulfa thing have to do with furosemide? Well, I pulled up the chemical structure of furosemide, and you can see there's a sulfur right here on the end of it. This is a common medication that patients have an allergy to. It's one of the ingredients in Bactrim DS. It's sulfamethoxazole. You can see the sulfur right there in the drug structure. Just to give you an example of what the chemical structure and what this actually drug looks like. All right. So dosing of it, usual doses is anywhere from 10 to 80 milligrams IV for adults. The peds dosing is anywhere from 1 milligram per kilogram. Monitoring, I already talked about before, monitor blood pressure, monitor electrolytes. You can't monitor for electrolytes. So obviously if the person's had a history of low potassium, you can monitor for cramping. Sometimes that's a sign and symptom of low potassium. Maybe they have a history of high potassium. You can take a look at them on an EKG. Their T waves are huge. Then you know maybe something else is going on with the patient. So it's supplied usually as vials. There's only really pretty much one concentration that's out there. So 10 milligrams per ml. Usual recommendation is like 10 milligrams per minute. So you're going kind of slow. So usual dose kind of right in the middle of our range is like 40 milligrams. So that's a 4 milligram IV push. All right. Thiazide type diuretics. Thiazide type diuretics are a little bit different because they don't work in the loop of Henle. They work a little bit further down the pathway on the nephron, on this smallest operating cell within the kidney. So they work on the distal convoluting tubule. And what they do in the distal convoluting tubule is they block the reabsorption of sodium, chloride, and potassium. But most thiazide type diuretics, you don't get as much diuresis from them as you do the loop diuretics. And why is that? The reabsorption's already happened before the fluid actually got to the distal convoluting tubule. All the reabsorption happened in the loop of Henle. So there's only going to be a 10% of the sodium, the chloride, and the potassium left in the tubule for you to block the reabsorption before it gets out in the urine. So that's not much, all right? So why are these things used so often? Why is hydrochlorothiazide used on every single med list that you see out there? It's used on it. Because it works for hypertension. It works for high blood pressure. They don't know how it works. It's different. It has a different mechanism of just causing the diuresis that it works. Now, you'll see more and more of this other drug that's similar to hydrochlorothiazide called chlorothalidone being prescribed, all right? Now, the latest guidelines that came out about a year ago recommends the second drug called chlorothalidone over hydrochlorothiazide because the half-life is longer. So it works longer in your body, all right? Most patients only take the hydrochlorothiazide and chlorothalidone once a day, all right? So if you have a drug that lasts longer in your body, you're going to have better effects from it. So you're going to have more of a hypotensive, maybe not so hypotensive, but normotensive effect, okay? They give it for patients who have hypertension. Their blood pressure is reduced. We want to keep it reduced. We don't want this fluctuating kind of roller coaster ride that patients are going to be going through. All right? What about this other one down here? Has anyone ever seen this on a med list, metolazone? I got a hand up front. Anyone else? Metolazone. It's only available orally. It's not available IV. It works just like your other thiazide-type diuretics, but it's more potent. All right? You'll usually always see it given in combination with a loop diuretic. So different mechanisms, they're all diuretics, okay? So we give this metolazone first, and then 30 minutes later, we give a loop diuretic. So they work in different parts on the nephron. They're both going to be blocking the sodium chloride potassium reabsorption, and you get a huge amount of diuresis associated with it, okay? Those are those patients that are on like 80 milligrams of Lasix twice a day, or 80 milligrams of furosemide twice a day, and they still have fluid retention. And the doc says, well, okay, you're still gaining weight, you're still having all this swelling. We're going to add metolazone 3 times a week. So Monday, Wednesday, Friday, you're going to take a drug like this, metolazone. It's going to work in a different part of the kidney. It's going to cause you to pee like a racehorse, all right? And it does, and it's very, very potent. Any questions about that? The reason why they do this last one, this metolazone, more so than the hydrochlorothiazide and chlorothalidone, is that you can actually use the metolazone down to patients who have this decreased renal function. And it's shown that metolazone actually works down to patients who have this decreasing renal function that maybe the hydrochlorothiazide and chlorothalidone really isn't working that well. So this raises another question then. What if you give it to a patient who has kidney failure? What if you give a diuretic to a patient who has kidney failure or is on dialysis? What do you think? Well, the acute kidney injury or kidney failure, you might be causing more harm on that, okay? Because if you have an injury to the kidney and now you're causing decreased intravascular volume because you're causing more diuresis, you may cause that blood supply to the kidney to constrict off because your body's like, hey, I don't want to lose any more fluid, all right? I don't know what you're thinking about, but I want to keep whatever fluid I have on board. So I'm going to constrict that blood flow supply to the kidneys even more, okay? You may cause some harm here in these patients who have acute kidney injury, all right? If you give a diuretic to a patient on dialysis, What do you think is going to happen? Probably nothing. It depends on the person. Now, some dialysis patients they don't have any urine output, and some dialysis patients have some urine output. Okay, so on those patients who maybe have some urine output, you may get a little diuresis from them. All right, and those patients who don't have any urine output, it's not going to do anything. All right, the kidneys aren't functioning anyway. The drug's probably just floating around your bloodstream and probably causing more adverse drug reactions. All right, more side effects. One of the things that furosemide does, and I didn't talk to you about, is it increases your sensitivity to the sun and sun exposure. So someone who's on Lasix, who goes out and, well, not a day like today, but a nicer day, they may sunburn really, really bad. They may also get a rash or a sunburn even if they're taking, or even though they applied sunscreen. All right. If you're giving furosemide to a person that you're transporting that has excess fluid, you're not going to cause them any harm, but it's not going to work either. Does that make sense? What about this second part right here? You're transporting a 20-kilogram child who has a history of a heart transplant and short of breath and has 3+ pedal edema. What's the appropriate dose of furosemide? 20 milligrams. So a milligram per kilogram. All right. How many cc's is that? 5 cc's? I heard 2 cc's. 10 per 1, 2 mLs. And how fast do you push it? 2 minutes. Good, good. I want to give you an overview of antibiotics and antifungals and a little bit about how they work and what they actually work against. So listed up here is your common organisms that you're going to be pretty much going up against, and these are gram-positive organisms. So a lot of your activities against MRSA or methicillin-resistant Staph aureus is going to be active also against these other gram-positive organisms. So top of the list, I have Staph aureus. The second one, strep pneumonia, MRSA with this methicillin-resistant Staph aureus. Next one down is Enterococcus. So where are these organisms usually located? Okay. Everywhere on your body or somewhere on your body, right? So Staph aureus is usually on your skin, soft tissue. It can get into your lungs, can get into your nares. Strep pneumonia is usually the chief organism that's responsible for causing pneumonia, ear infections, sinusitis. That's usually where that specific organism is located at. Strep, not specifically strep pneumonia, but strep, whether it's group A, B, C, or the other varieties, is also associated with strep throat, but also is located on our skin too. That's some of our what we call normoflora, which is something that everyone's carrying around with them every single day. It's not causing an infection, it's just living on our skin. All right. Methicillin-resistant Staph aureus, actually some of us have that on our skin. I probably have it on my skin. It's just something with being in an institution, being around a bunch of patients that have MRSA, you get exposed to it. That's also responsible for causing pneumonia, cellulitis. It also can cause sinusitis too, skin abscesses, etc. Post-operative wound infections, most of the time they have methicillin-resistant Staph aureus in them. So Enterococcus, whether it's Enterococcus faecalis or Enterococcus faecium, where are these things located at? GI, they're in a stool. Exactly right. So we cover for these organisms a lot if we're doing a procedure where we're doing like an API, or we're doing a post-operative wound infection or anything like that. Sometimes those infections are associated with Enterococcus. There are cases where Enterococcus gets in our bloodstream and can cause some really problematic cases of endocarditis too. So a lot of our treatments for endocarditis are treatments that cover for enterococcus. I mean, there's been a huge push to clear MRSA out of the nose. So they use these nasal swabs. It's called Bactroban or mupirocin, and they'll swab the nose twice a day for a week, 5 days, maybe even longer than that, to clear the patient's MRSA out of their nose. That's where they culture it, that's where it comes from, that's where it kind of lives sometimes in these patients. Now, the data comes from these patients who are carriers of MRSA having maybe cellulitis, maybe having post-op complications because they have MRSA in their nares. So I don't really have a good answer as far as like whether you should put a mask on them or not. I think if you swab most of the people in this room, I think that they would come out positive with MRSA in their nares. It's whether if you have like something that suppresses your immune system, if you've been running for 48 hours without any sleep and you've been eating like crap, or maybe you're now an oncology patient that you're getting radiation or chemotherapy and you're maybe a little bit more susceptible to infections, maybe you will get an outbreak of MRSA. Did you work yesterday?
Yes.
How many people did you transport yesterday? 6 people. How many times did you change your clothes that you wore yesterday? Once. So if the first person that you transported had MRSA on, and now you're wearing it, the rest of the 5 people that you transported are now exposed to it.
Well, I mean, if you know, we all have it in our nares.
Oh, true. Well, I think that it's more of you don't want to really contaminate other people. They may have another strain. It's good for infectious control standards to not carry that around with you and to not give that to other people that you're exposed to. Nurses are out of one room and into another one rapidly. You're transporting other people rapidly. You might not be, changing your clothes, wiping down your rig, anything like that. It's mostly to protect you, but also to protect other people. Even though we mostly all have MRSA in our nares, being exposed to it more and more may potentiate an infection more in you. Okay, maybe you have a little cut on your finger, and now you're transporting a patient from one cot to another cot, and now you got MRSA in your wound. You know. Yep. So a little bit about the antibiotics, and I'll go through this pretty quick. Cephalosporins. So remember what I told you about extrapyramidal side effects? That's like the big category, and then there's subset categories. Cephalosporins. When I say cephalosporins, it's a big category. Beneath cephalosporins is a whole bunch of other antibiotics. And there's also subcategories between that with first generation cephalosporins, second generation, third generation, fourth generation. Now there's a 5th generation cephalosporin that's out. Okay, carbapenems. These are the big, broad spectrum antibiotics that you'll probably only see used in the ICU. This is like kill 'em all antibiotics. One of our ER doctors likes to refer to these carbapenems as liquid Jesus because it works and it pretty much kills all the bacteria or whatever is infecting you. The last antibiotic is antibiotics for MRSA or methicillin-resistant Staph aureus, vancomycin, daptomycin, and linezolid. So there's also other ones out there. So antibiotics against MRSA, vancomycin, daptomycin, linezolid. Other categories of antibiotics are aminoglycosides. You'll probably only see these used in combination with other antibiotics. Gentamicin, tobramycin, specific antibiotics that are used for endocarditis, treatments of urinary tract infections, but they're also, they work great against a growing resistant bug called Pseudomonas. So Pseudomonas is a gram-negative organism. The chief organism that's going to be causing urinary tract infections is something called E. coli. These organisms work great against it, and Some of the things that we're using it for treatment against endocarditis is more of the gram-positive organisms like Enterococcus or staph or strep. And the aminoglycosides work great because they work synergistically with other antibiotics, so you get a better killing effect with this infection that's going on. So anaerobe coverage. So where do you think anaerobes live in our body? Intestines usually, yeah. There's not a lot of bacteria that lives in our stomach. It's pretty, what's that? H. pylori is one of them, yep. But the acidic environment in our stomach is so acidic that you really can't get a lot of bacterial growth. The H. pylori is something that's responsible for causing ulcers and ulcer formation. The H. pylori kind of walls itself off and eats away at the stomach lining. Anaerobes live in our GI tract where there's not any oxygen, so anaerobic activity. Antifungals, the only one I'm going to be talking about pretty much is fluconazole or diflucan. So the first antibiotic category on the list is cephalosporins. First generation cephalosporins, as we transition through first, second, or third generation, fourth generation. First generation really only cover gram-positive organisms. So methicillin-sensitive Staph aureus, strep is also, you're going to get coverage with that, but mostly gram-positives. Cephalosporin, it really only covers about 1 or 2 gram-negatives. The 1 gram-negative is going to be E. coli, and it does actually work for urinary tract infections. You will see Ancef or cefazolin used as a preoperative antibiotic prior to doing surgery. So why do you think they use it preoperative? Prevention of antibiotic, yep. Most of us have normal bacteria that lives in our skin. And those skin organisms are usually staph and strep, okay? First generation cephalosporin, like cefazolin, kills staph and strep. So if we're going to be doing an incision on somebody, we kill that bacteria. We also scrub them up, chlorhexidine prep and stuff like that, to make sure that we don't have any bacteria that sort of jump into the wound. We make the incision, close them back up, and they're fine. They heal well. But it gets anything that kind of avoids the scrub that we do, the chlorhexidine prep, and everything else prior to that incision. So as a class, the cephalozolins, the structure-wise, is similar to penicillins. So we always have to ask our patients, are you allergic to penicillins? And there's a small amount of patients that can cross over reactions from penicillin allergy to a cephalosporin allergy. So the more severe the penicillin allergy is, the more we're concerned about this cefazolin cross-reactivity. So if I have a really bad reaction, like a Stevens-Johnson syndrome, where I have an anaphylaxis, shortness of breath, difficulty breathing, either one of those things, I'm not going to use a cephalosporin in them, all right? If someone comes to me and they say, hey, I had amoxicillin when I was a kid, and now I'm 35 years old, but when I was 5 years old, I had amoxicillin and I had a little rash on my stomach. Well, I think that's okay that you can go right ahead and use a cefazolin or cephalosporin on, no problems at all, right? The more we're exposed to antibiotics, the more side effects that we can have. Rash, diarrhea, Stevens-Johnson syndrome, we can still have those even if we don't have a penicillin allergy in the past. Usual doses of it, this is more of a weight-based drug. Somebody that's maybe 60 kilos, 70 kilos would be getting a 1 gram dose. Someone that's 80, 90, maybe 100 kilos would be getting a 2 gram dose. Anybody greater than 120 kilos is usually a 3 gram dose. You don't really have to worry about the infusion too much, but they goes in pretty rapidly, over 30 minutes. PEDS dosing is usually 25 mg per kg. Supplied, you can get some really big like 10-gram vials that we use in the hospital. Most of the time that you'll be getting supplies of either 500 milligram or 1,000 milligram vials. So one of the ones, also another one that we use commonly in the hospital is something called Rocephin or ceftriaxone. It's a third-generation cephalosporin, so still under that cephalosporin kind of category. Third-generation cephalosporins, they actually cover more and more gram-negative organisms. All right, that's the differences in the generations. It also gets your gram-positive organisms, but it's converting over more and covering more and more gram-negatives. Rocephin is a very common antibiotic used for urinary tract infections, used for treating pneumonia, specifically the community-acquired pneumonia, because it covers a lot of resistant strep pneumonia out there. It's very, very well tolerated. Infusion goes over 30 minutes. Sometimes in kiddos that we don't have an IV established, you can actually give it in an IM injection, and it hurts. It hurts a lot. All right. We mix it with lidocaine to kind of help with that, but it still hurts. Kids dosing with ceftriaxone or Rocephin is 50 milligrams to 75 milligrams per kilogram every 12 to 24 hours. Adults are usually like a gram or 2 grams every 12 to 24 hours. Another interesting thing that you can give ceftriaxone for is meningitis or CNS infections. Ceftriaxone crosses the CNS really easily. So the bigger the drug structure is, the less potential it has to cross our CNS. Also, the less lipophilic it is, the less likely it is to cross our CNS. So when I say lipophilic, I mean like lipid-loving. So if it's, and drugs have different properties to them. So drugs that are maybe more soluble in lipids are maybe more soluble in like organic compounds like acetone or other things. So you think about like oil-based paint, all right? You can't clean oil-based paint with water. You have to use paint thinner or acetone, all right? So drugs are the same way. Drugs can be either water-soluble or lipid-soluble. The more lipid-soluble a drug is, the easier it is for it to cross the CNS. Other antibiotics that you can use, cefepime is a common one. This is a 4th-generation cephalosporin. So as you transition from a 1st-generation to 2nd-generation, 3rd-generation cephalosporin, 4th-generation cephalosporin like cefepime, what additional coverage does it provide you? Coverage for Pseudomonas. So in the community, Pseudomonas is not that rampant out there. It's not causing infections. It's not making people sick. But someone living in a nursing home, someone that's been in and out of a hospital multiple times, they're more and more exposed to Pseudomonas, the more chances that they are going to have for this type of infection. Okay? The other one up there is called Zosyn. Piperacillin with tazobactam. Okay? Piperacillin is it's a penicillin that has an anti-pseudomonal activity against it. So in the healthcare setting, we really worry against this organism called Pseudomonas because over time, unlike the other organisms, it's rapidly growing resistance left and right. Okay, so we take the infection very seriously. Sometimes when we're treating a Pseudomonas infection, we not only use one drug that covers Pseudomonas, but we double cover it. We double cover it because of fears that we have that by just using one antibiotic to cover that specific organism, the more that we expose that specific organism to this antibiotic, the quicker the resistance is going to grow to this antibiotic. And so we use 2 antibiotics up against it, not because we want to wipe out the infection rapidly, but because we're worried about resistance. Cipro. So I don't have a slide for that. That's a very good question. So Cipro is the brand name. Ciprofloxacin is the generic. other drugs in that class of medication. The class of medication are called quinolones. All right? Levaquin, brand name. Levofloxacin, generic name. Avalox, brand name. Moxifloxacin, generic. All of those are considered quinolones. The very, very first quinolone out there is Cipro or ciprofloxacin. It's technically, I think they call it a second generation quinolones. There's not anything that's a first generation quinolone, okay? Moxifloxacin and levofloxacin, they're both third and fourth generation quinolones, all right? So the differences in between changing from a second to a third and a fourth, your quinolones actually do cover Pseudomonas, but they cover it only a little bit, all right? So this Pseudomonas is actually gradually growing more and more resistance to quinolones. And that's concerning for me because there's not really a good option that patients can take an oral medication to treat Pseudomonas on the outpatient side. These quinolones are our last hope, all right? Quinolones cover gram-positive organisms. They cover your strep. They cover your staph. They do not cover MRSA. And some people say that they do, but the resistance that forms to MRSA is very, very rapidly if you're going to be using a quinolone as the only drug therapy, or what we call monotherapy, to that specific organism. All right? You can use it for sinusitis. You can use it for bronchitis. You can use quinolones actually for urinary tract infections. Okay? They do cover some gram-negative organisms like Pseudomonas I talked to you about, but they also cover E. coli too. E. coli is our chief bacteria that's going to be causing urinary tract infections. All right? E. coli is also a problem for causing some GI issues too. So sometimes you'll see it, quinolones used for diverticulitis, but you'll usually see that in combination with other drugs that cover more anaerobes, okay? Cipro doesn't cover a great amount of anaerobes. The one out of all of those three that covers a large amount of anaerobes is actually Avalox, or moxifloxacin. ESBL. It stands for extended spectrum beta-lactamase. All right? So it's one of these broad categories, okay? Below ESBL, you can see specifically identify different organisms. So ESBL is like an extended resistant organism. E. coli is an example of an extended ESBL organism. Not all E. coli is an ESBL organism. All right? It's kind of like the difference in between like MSSA, which is methicillin sensitive Staph aureus, and MRSA. Okay? So they say ESBL, but they don't specifically identify the organism. E. coli is one. Another one is Klebsiella. So Klebsiella pneumonia and E. coli, both of those are ESBL organisms. Healthcare institutions worry about those a lot because there's this organism that's out there that's growing that's now having a lot of resistance to other antibiotics. Liquid Jesus over here, this is meropenem, imipenem. This actually covers ESBL organisms. So whenever there's that concern, the institution takes it very, very serious. So maybe they get 1 or 2 cases of postoperative wound infections, and they culture those postoperative wound infections, and it grows out an ESBL organism, or it grows out a specific chain of like vancomycin-resistant enterococcus, and we take it very seriously. We shut the place down. We figure out where it came from. Did someone not wash their hands? Did this organism get underneath their fingernails, and now they're going and they're contaminating everything? All right? Is it on an instrument in there? Is it on some sort of robotic? Maybe the robots are doing knee replacement surgeries. Shut it down, clean it up, figure out where it's coming from. They usually start culturing a whole bunch of different things. And then once they figure it out, clean it up, then they'll reopen the site. So the doses of this one, there's a wide range. The one thing to really watch for is the Primaxin, or this imipenem Celastin. The higher the dose that you get, the more chances of it actually crossing the CNS, and that becomes problematic because it actually causes seizures and causes seizure activities. So if you're thinking about CNS infections, really the carbapenem of choice is to use meropenem or Mirum. That actually crosses into the CNS. That can actually have some bacterial killing effect, but that one doesn't cause seizures. Most institutions have transitioned over into meropenem only for use worldwide. So that's our formulary choice. If you've heard about institutions that develop formularies, and you, why do they develop formularies? I don't get it. Is it just for a way for them to cut down the drugs that they use, or to have more profits from it? Sometimes not. Sometimes it's because of safety issues, all right? So if there's a specific surgeon that loves to use imipenem, and he loves to dose it really, really high, and he's not worried about CNS side effects, and then 2 days post-op, all of his patients start seizing, specific formularies have only specific drugs on formulary because of some safety issues too. Vancomycin, vancomycin, okay? This is an interesting antibiotic that's been around for a long, long time, all right? It's been around so long that when it first came out, there was a lot of impurities with it. It was black, and it was very, very dark colored when it was infusing. And it was called Mississippi mud, actually. All right. Along with a lot of impurities, there was a lot of side effects that it first had when it first came out of the market. So, caused a lot of renal problems. So a lot of acute kidney injuries and a lot of renal failures were attributed to vancomycin. Ear ringing, toxic effects in the ears. But you'll also hear some things about an infusion-related reaction called red man syndrome. Now, most of the other things have pretty much all fallen to the wayside. Pharmacy pretty much follows a lot of the vancomycin levels in these particular patients, so the levels really never get high enough that they can cause toxicity. A lot of the impurities are gone in it, so when you get a bag of vancomycin, it's actually a clear liquid. We figured out a lot of the infusion-related reactions, so we actually slow the infusion down. So you'll have infusions that last an hour and a half or 2 hours for this particular medication, and that prevents a lot of these red man syndromes that are associated with it. So an example of what a red man syndrome actually looks like: the drug is infusing in, the patient starts itching their scalp, the back of their neck itches, down towards the back, their arms start itching, okay? And you look at it and it's beet red, all right? Sometimes their legs, but you never really see it a lot of times tracking up their IV site. Sometimes you do, sometimes you don't, okay? So my question for you is it an allergic reaction? And how do you manage these patients? So say you're taking a patient out of the Oconomowoc ICU, and you're transferring them to Froedtert because that's where they want to go. Oconomowoc did what they needed to do, but there wasn't enough care for them over there. It was a patient choice. They wanted to transfer to Froedtert. And Oconomowoc started them on vancomycin. Like, well, their dose is due. We talked to the physician over at Froedtert. They want to continue this antibiotic. I got started. Now remember I said that this antibiotic goes in over very, very slowly, okay? 2 hours. They started it. You're here to pick them up. You don't want to wait 2 hours till the antibiotic's done. So you keep running it, all right? The patient starts developing this red man syndrome, okay? They start itching, all right? They start to develop redness. What do? Stop it? You can do that. You can stop it, flush it. No problem at all. Vancomycin lasts in your system for a really, really long time. It's usually dosed every 8 hours or every 12 hours. So there's no problem at all with stopping it. What about slowing the infusion down? Red man syndrome is an infusion-related reaction, okay? Slow it down. It usually develops within the whenever you're infusing the drug itself.
You mentioned
Well, it can be either initial or subsequent doses. So sometimes patients are on this for a prolonged period of time. They'll use vancomycin for osteomyelitis infections. It's very, very difficult to get an antibiotic to infuse into bones, all right? So what we rely on is a prolonged period of time of exposure to the specific organism with the antibiotic. So we're talking like 4-6 weeks of therapy for this specific medication, all right? At any time throughout that 4 or 6 weeks, a patient can develop this red man syndrome with an infusion-related reaction. The other thing that you can do outside of slowing the infusion down, stopping it, is you can actually give Benadryl or diphenhydramine. Now, you start thinking about, well, it's not an allergic reaction, all right? Why does Benadryl work? Well, I think it helps somewhat with the itching. And that may be somewhat anticholinergic, but there also is somewhat of a histamine release too. But it's not a histamine release related to an allergic reaction. So it can make patients feel better relatively quickly, okay, especially if they're really, really uncomfortable, all right? And sometimes patients, remember the example I talked to you about before, the osteo infections and the bone infections, patients are on it for 4 or 6 weeks. I've seen infectious disease doctors write for Benadryl to be given prior to their infusion of vancomycin for 6 or 8 weeks, all right? Now, we never give an antibiotic or we never give any medication to a person that has an allergic reaction to them. So that's why I'm telling you that this red man syndrome that develops after giving vancomycin is more of a side effect of the medication related to how fast the infusion is, but it can be relieved by Benadryl, but it's not technically an allergic reaction. It's more of a side effect. Antifungal medication that's very, very common is amphotericin, amphotericin B. They have a nickname for it. They call it amphoterrible. Amphotericin B, it causes patients to have rigors and start shaking a lot, but it can also cause redness. We pre-medicate them with large fluid boluses. We also pre-medicate them with Benadryl. A lot of times on oncology floors, patients will start developing these, maybe a fever, maybe some chills and things like that related to blood infusions. So oncology, I mean, we're giving chemotherapy. It's curing their cancer, but it's also wiping out all their white blood cells and red blood cells, and it's causing them to become what we call neutropenic and pancytopenic, which is pretty much all their blood cells and the production of blood cells have pretty much stopped. So we have to give them blood transfusions. The more blood transfusions that patients get, the more types of reactions that they get to that. So the morphine is a histamine-related reaction. So when you compare morphine to hydromorphone, morphine is a more pure opioid, an opiate, that you get a lot of this histamine release, not necessarily an allergic reaction. Most of the time, the patient's not going to say, hey, I'm having shortness of breath, I can't breathe, my airway is closing up. They just start itching. And a lot of times, the morphine reaction is related to a lot of the dose. The more doses that you give, the more medication, dose after dose after dose, the more itching that they're going to get. I've had drug addicts that have come in that are high, they're itching all around their abdomen because of all the opiates that they're exposed to, regardless of whether it's morphine or anything else like that. They get the itch. Yeah, they're itching all over. Heroin is another one that's more of a pure opioid. It's not a synthetic opioid. It comes from the opioid or the poppy itself. So there's one other thing that's related maybe somewhat to an infusion-related reaction, and that's kind of becoming new. And that's it's this red streaking that you get from Cipro or levofloxacin. Okay, so Cipro, ciprofloxacin. I've seen this a number of times, and it's actually a change in some of the formulation, the IV formulation that's out there. So a number of times I've had nurses come to me and say, hey, I'm running Cipro in a hand, and I'm following this vein up, and this vein is all red all the way up. Now, they're not having any itching. They're not having any hives. They're not having any redness all over the body. It's just this red streak that's followed where the drug is actually being infused. So this is almost kind of what we call thrombophlebitis. It's an irritation on the vein itself, all right? And it follows the vein all the way up. Now, if you give Benadryl, it probably will help. It'll cause that redness to go away pretty quickly, especially if you give it in the IV site that you're running the antibiotic in. You can slow the antibiotic infusion down. You can give it with other medications so the medication kind of gets more diluted as it goes into the vein. You'll have less and less of an issue with this thrombophlebitis that can happen with it. So I don't really want you to know too much about the troughs, but vancomycin is, back to vancomycin. Vancomycin is a drug that we measure concentrations on. Gentamicin, tobramycin are also medications that we measure concentrations on. Most of it is to make sure that we get the medication at a specific concentration, so it's working against the antibiotic. But the gentamicin and tobramycin is to make sure that we don't have any toxic effects like nephrotoxicity and ototoxicity. And you'll hear more about toxicities related to gentamicin or tobramycin, which are the aminoglycosides, than you will with vancomycin itself. So I talked about it, but I'm going to repeat it. Gentamicin, tobramycin are usually used to treat UTIs, endocarditis, and pneumonia. They're usually used in combination with other drugs, but the pneumonia is usually gentamicin, tobramycin are active against strep, but they're also active against Pseudomonas too. Gent and Tobra double cover for Pseudomonas. Like I said, this is one of those organisms that's increasing in resistance. Clindamycin. These all sound the same, don't they? They all end in mycin. So if you're allergic to a mycin, you must be allergic to all the mycins, right? No. So pay attention to which category and which subcategory these fall into, all right? And that'll help you with differentiating between allergic, patients who have allergies to one medication and whether you can safely give them to a patient who has another allergy. So penicillins. This one is not related to any penicillins. So if anyone says, I got allergic to amoxicillin, can I take clindamycin? Well, after taking this class, you can say, sure. It's in a different class. Clindamycin actually covers anaerobes. It does cover some methicillin-sensitive Staph aureus. It does cover some strep, very, very weakly. It does cover a community-acquired strain, so a community-acquired methicillin-resistant Staph aureus. That covers it weakly. So very, very weak against this. About 60% of the strains of methicillin-resistant Staph aureus are covered by clindamycin. So that's really not good enough to say, hey, if you're hospitalized and you have methicillin-sensitive Staph aureus, I'm going to use clindamycin to treat your infection. I wouldn't feel confident with that. 60%, that's not even a passing grade, is it? No. So other things that it's great for is it does cover dental abscesses in patients who have an allergy to penicillin. What we would usually use for like a dental abscess or a dental infection, you can use clindamycin on. It covers a lot of the GI effects. The other thing that it does not cover is it does not cover an organism that lives in our GI tract called Clostridium. So you have an antibiotic here that covers pretty much all the anaerobes except for Clostridium. What do you think is going to happen if you keep giving clindamycin to somebody without stopping after 10 days? So say they're on clindamycin for a month. C. diff. That's right. You're going to wipe out all that good bacteria that live in our GI tract, and you're going to cause another bacteria that lives in our GI tract called Clostridium to overpopulate. Patient's going to have diarrhea like there's no tomorrow. All right? Then we're going to have to put them on another antibiotic that covers Clostridium just to wipe out that infection. So it's a good antibiotic for what it covers, but it's also a little bit bad because you have to monitor the diarrhea associated with it, if the diarrhea becomes problematic, then you'll see a lot of physicians culturing for Clostridium or a C. diff culture. So it's available as orally, it's available as IV. Like I said before, monitor for severe diarrhea. Covers all anaerobes except for C. diff. Another antibiotic that covers a lot of anaerobes that they use prior to surgery is something called Unicin or ampicillin sulbactam. So if I had a penicillin allergy, could I take this medication? I hear a couple heads shaking, no, can't. All right? This ampicillin falls underneath the penicillin category, okay? But we group it with this other antibiotic called sulbactam to make it a super antibiotic, okay? Antibiotics over time, since they were developed, have gradually grown resistant. Sulbactam is what we call a beta-lactamase inhibitor. So beta-lactam is actually, it's an enzyme within the bacteria that takes the penicillin and starts pumping it out. So ampicillin can really only activate if it gets inside the cell itself, inside the bacterial cell. Bacteria know this and they say, hey, get out of here. You're getting out. So we give them something else that's a beta-lactamase inhibitor called this sulbactam that inhibits that enzyme from kicking this antibiotic out of the system. So it gets in concentrations inside the cell wall, inhibits the replication of the bacteria, and starts working. Penicillins, they work against gram-positive organisms. They work against some gram-negative organisms, especially if you pair them with this beta-lactamase inhibitor called sulbactam. But in the notes, you'll see that this one is good for anaerobes. It works great for GI infections. Diabetic foot wounds, this works good. All right? If you're taking the person to a lap chole, this one's going to work good. All right? An open appy, this is going to work great. It's going to cover all the anaerobes in your GI tract, but it's also going to hit the gram-positive organisms that cover our skin and populate our skin too. Things to watch for too, though, is also diarrhea, abdominal cramping. The diarrhea is also something you have to watch for with C. diff too. This antibiotic covers a lot of the anaerobes, but it does not hit Clostridium difficile. All right? There's a couple of treatments for Clostridium difficile. One of the ones I've already talked about is called vancomycin. So vancomycin you actually take orally instead of taking it IV for the treatment of Clostridium. And the reason why is vancomycin is a structure that's so huge it has a hard time crossing the intestinal walls. So if you give vancomycin orally, you're never going to be able to detect a blood concentration on vancomycin. On the flip side, if you give vancomycin IV, it has a really hard time getting into the GI tract to fight infections for Clostridium difficile or C. diff infections. This is an infection only in the GI tract and causing that population of that bacteria. Last antimicrobial I'm going to be talking about is fluconazole or diflucan. So different from bacteria, this is a fungus, all right? Sometimes you'll see this available as an oral. It's working against Candida. It can work against patients who have yeast infections. It can also work for systemic blood infections caused by Candida. It can also actually cross over into your CNS. You'll really never see it used as monotherapy for things like meningitis. You'll usually see it in combination with other things to treat meningitis. When fluconazole came around, it was a really, really problematic drug for the pharmacy because it caused a lot of drug interactions. It interferes with how medications are metabolized via the liver. You don't have to worry about that, and so I really didn't put it up here. But one thing you do have to worry about is prolonged QT. And it doesn't have a pretty prominent effect on that. So not so much if the patient's only taking diflucan and no other medications that prolong QT, but you go ahead and put them on diflucan and put them on amiodarone, maybe put them on Ticicin, other drugs that can prolong QT, and now you got a problem. their QTc is over 500, they maybe become bradycardic, all right? Their QT becomes longer and longer, and what do you get? What happens if your QT gets too long? What heart rhythm do they go into? Usually torsades. Usually torsades, all right? So that's the issue with prolonged QT. You never want the QT to get too long because they start getting into this fatal heart rhythm. And even if you get them back from torsades, you shock them back and then they go back into torsades. You shock them, they go into normal sinus, and then they go back into torsades. And you're like, crap, what's going on? What do I do? What do I do? You know, you give them fluids. You know, try to correct the problem. You give them some mag if you want. That hopefully corrects the problem. But if you would have caught it earlier and you would have detected the fact that they were on a medication like diflucan or fluconazole that actually prolongs your QT, you can stop that before even the problem started. Dosing, like I said, it's available orally, it's available IV. You don't really have to worry about this, but some special consideration with renal impairment. If patients who are like acute renal failure or dialysis patients, we don't have to give it to them as often. Usually it's every other day, low dose once a day, etc. Non-steroidal anti-inflammatories. I'm switching gears. I'm going back. So we initially talked about a little bit about some non-steroidal anti-inflammatories on the first lecture. Things that you're familiar with that are non-steroidal anti-inflammatories are Toradol, Ketorolac, all right, ibuprofen, naproxen, ketoprofen, Arudis. Indomethacin is another one that's available as a non-steroidal anti-inflammatory. Another one is called Mobic or Meloxicam. This is another one. Celebrex, celecoxib. That's in a fancy one that's called a COX-2 inhibitor. But it technically falls underneath the category as a non-steroidal anti-inflammatory. So what do these medications do? They work peripherally by decreasing the amount of prostaglandins actually that you produce. So they decrease this inflammatory cytokine that we have called prostaglandins. Inflammatory, so if you injure your knee swells up. You take an anti-inflammatory like ibuprofen or anything like that, it's going to inhibit those prostaglandins. Your swelling in the knee goes down. Okay? Your body is exposed to something that causes a fever. All right? Some sort of bacterial infection. You're running a fever. You got a whole bunch of prostaglandins released. You take an anti-inflammatory. It decreases the amount of prostaglandins. It also decreases the fever. You get a fever reduction in this. Most pretty much across the board, any anti-inflammatory is going to have some sort of antipyretic or fever-reducing property to it. So does Tylenol fall into this category or acetaminophen? I see some head shaking. No. Another no. Why not? It reduces fevers. It helps pain. Doesn't have a peripheral acting anti-inflammatory property to it. So it's all about this peripherally acting analgesic property of reducing the prostaglandins. Peripherally. Tylenol works in the CNS. It's a centrally acting prostaglandin inhibitor, thereby reducing fever, reducing pain, or your perception of pain in your CNS. All right? Because it only works in your CNS, you're not going to see the side effects associated with peripherally acting. So, the side effects like GI bleeding, Ketorolac. Look at this. Patients have a history of GI bleed. Use caution in it. If you use it for longer than 5 days, your risk of GI bleed goes way up. So in the hospital, we always have an automatic stop time of 5 days. Can't take it more than 5 days, your GI bleed risk goes way up. And the benefits of using the medication don't outweigh the risks. Other non-steroidal anti-inflammatories are completely different. So things like ibuprofen, you can take it for a longer period of time. The longer that you're exposed to, the higher doses that you're exposed to, the increased risk of GI bleeding goes up and up and up. And that goes across the board for any any non-steroidal anti-inflammatory that you take. All right? Now, I've really only put the dosing down for ketorolac or Toradol. This is pretty much the only thing that you're going to be given IV or IM. The doses in which you would give IM are double the doses that you would give IV. You have to take into account the age of the patient, also the renal function of the patient, and reduce it in patients who are older or who have decreased renal function. You do see some drowsiness associated with it. That goes across the board for all non-steroidal anti-inflammatories. You may ask, well, why do we give this medication if it causes GI bleed, if it causes stomach upset? There's specific patient populations that this actually works great for. Like I said before, that patient who has a swelling in the knee, you want to get the inflammation down, give them an anti-inflammatory. Works great. How about your patient who's complaining about flank pain and has had a history of kidney stones? What do you think about that patient? Give him morphine, give him Dilaudid, give him fentanyl. Toradol, yeah, worked great. Toradol actually causes a relaxation of your ureter. So it can help you pass the stone better. So patients who actually have kidney stones, some patients will say, you know, I get fentanyl and I get morphine and I just get all doped up and I get loopy and I don't remember my visit to the ER. But you give me Toradol and that helps. I can think straight. I can drive home. So patients who have had frequent kidney stones, some of them really benefit a lot from ketorolac or Toradol. Yeah, yeah, sickle cell pain crisis, sure thing. Yeah, and most of that is related to the anti-inflammatory effect of it too. Yep. Migraines too. Yep. Migraines you'll hear a lot in patients. Sometimes patients, they don't get a lot of opioids or narcotics. They work for migraines, but the problem is that sometimes they get rebound migraines. So we give them Dilaudid, we give them fentanyl, the migraine goes away, great. We get them discharged from the ER, 4 or 5 hours later, migraine comes back. Sometimes this anti-inflammatory property of the Toradol actually helps by decreasing the rebound effect, but also decreasing or getting rid of that initial migraine and migraine effect of the medication. If you want, I can stop here and I can start up next time with this topic.